Hello and welcome to the Global Health Matters podcast. I'm your host, Garry Aslanyan. Many of you who work in global health know that there is growing momentum in global health research to support the creation of research ecosystem that is free from residual colonial practices and thinking. Of course, the majority of low and middle-income countries have achieved independence and have been decolonized. But yet, there remain tensions in global health research and practice that hold back fully country-owned and country-led initiatives. Scientists in countries, and particularly in Africa, have taken a leading voice in this discussion. So today, to take a deeper dive into this topic, I'm going to be joined by Catherine Kyobutungi, who is the Executive Director of the African Population and Health Research Center in Kenya. And my second guest will be Agnes Binagwaho, who was the Minister of Health of Rwanda from 2011 to 2016, and is currently the Vice Chancellor of the University of Global Health Equity in Rwanda. I have no doubt that the viewpoints that we will gather from Catherine and Agnes will make for a very thought-provoking discussion. So welcome, Catherine from Nairobi, and welcome, Agnes from Kigali.
Thank you for having us.
So happy to be here.
Maybe we could start by you sharing with the audience what was the inspiration that led you to pursuing a career in health and global health. Let's start with Catherine.
I was born and raised in Uganda. I studied in Uganda. I went to medical school at the Makerere University and finished medicine and was posted to work in the middle of nowhere, really. This was a small health facility, no phones, no internet, no running water at the time. We used to use rainwater, no reliable electricity. And I spent 3 years of my life in that environment. But my turning point was saving a little boy who came with severe anemia and had had repeated incidences of malaria, and persuading the parents at that time to buy a bed net. They even had to save money and suspend paying their medical bills at this hospital until they could afford a bed net. I was able to help that family work through financial difficulties. A bed net at that time was about $10 equivalent, but we were able to work through that, and they were able to buy a bed net. And I was able to talk to this woman for hours until she understood what she had to do to protect her baby from repeated attacks of malaria. And every time I remember when I went to the outpatients and found this little boy climbing over the seats with the baby and the mother, every time I remember I get emotional. Because the mother they were not sick. She had just come to show me that the baby had survived, was now a toddler, and she had another baby. And she told me never in her life had she ever had more than one child at a time, because all her children were dying of malaria when they were infants. And so for her to have a second baby, to have 2 children at the same time, was such a big thing for her that she felt she owed it to me. So she had come to show me her baby and, of course, the toddler whose life I had saved. So for me, that was a turning point. And I think it affected my orientation towards public health as opposed to clinical practice.
Thank you so much, Catherine, for that. Agnes, what's your journey?
My journey is somehow simpler. It all started because I wanted to be a healer. I was a little girl. And after that, I became an adolescent. I still wanted, because I grew up in Europe and I was educated to stay there forever. In 1996, I decided to come back, and finding a health system that has to be rebuilt was totally different than coming and use my skills immediately. This was a tipping point. When I was in Europe, I was just saying, I need an incubator for a child, this weight. And it was coming in the world a couple of days later. Here, I need to learn so many things, the specification, the weight, everything. And after that, I need to learn how a system is made. We don't think so much when we work in a system that is working, that there is a system. You are just part of it. Before starting working as a pediatrician, it was a long time ago. HIV was still a nightmare because there were no treatment in Africa, very little capacity to diagnose, and no system to treat HIV and AIDS. And so I focus my attention to children affected by HIV and AIDS and the right to access care, because what was needed in Africa existed in the world, but we didn't have access to that. So it was a breach in our human right to health. So children, HIV and AIDS and human rights was what I was doing clinically, and also mobilizing to get access to health services. And also at that time, it was just after the 1994 genocide against the Tutsi. The health sector was not functional. Many people have been killed or fled out of the country. And we had to rebuild everything. So with colleagues, we started to rebuild it. We started at the same time we were fighting to get access to HIV. And from there, I entered in global health because I went to the global health, to the global arena to fight for the creation of global fund, etc., to provide access to HIV treatment and diagnostic to Africans.
This episode was inspired by recent articles written by both Catherine and Agnes, drawing attention to the challenge that impedes the achievement of a decolonized health research enterprise. In each article, they propose actions that can constructively move forward and get us to achieving healthier and more equitable research systems. Catherine, you were part of a group of African researchers who wrote an open letter highlighting these residual colonial legacies in research. Maybe you could briefly share with our audience what prompted you to take this action and to take up this issue.
Yes, what prompted us to write the letter, we call it the letter right now because it actually got legs and has resulted in a lot of changes, even in such a short time. So I think things add up over time. And this letter was written, at the time after all of us had been battered by the pandemic. And in the middle of the pandemic last year, there was also this Black Lives Matter movement. And after the world witnessing on camera, George Floyd his life being snuffed out of him, I think a lot of people really had some self-reflection about the kind of world we lived in, where somebody's life could be snuffed out, like in front of you of other people. And so it prompted a lot of self-reflection in global health practitioners, funding agencies, and there was a lot of debate and discussion and initiatives on diversity, equity, and inclusion. Institutions changed their policies and they set up new strategies. So this is the context in which this letter was written. And then lo and behold, we are sitting there, we are very active on Twitter, and somebody whom I'd never met, but now we are like allies, tweets something about an organization in the US making an announcement about how they had been awarded $30 million in a consortium of partners to do some work on building capacity for malaria. And the announcement had 7 institutions. There were 4 American, 2 British, and one Australian. And so out of these 7, there was not one single African organization. And these were the lead partners. And they were supposed to build capacity of national malaria control programs in 18 African countries. So that was the question. Was there no single African partner who could be part of the 7 that was named on this partnership? So we started tweeting. We created the real tweet storm. And then we got a response. And the response said, yeah, we are going to work with local partners. That is not the point. Why are there named partners and then those who are not named, who are sort of anonymous, and you're going to work with them? What is this thing that 7 organizations outside Africa are going to do to build capacity? Then it was, we are going to train national malaria control programs to design tools to collect data and design studies and analyze it. And I was like, wow. In every African country, there's a school of public health that has capacity to do this work. If you gave $30 million to 30 universities in Africa, and each of them go to $1 million, the impact they would have is greater than we're going to see from this kind of skilled initiative, where maybe 70% of the funding is going to go for overheads, and it will never reach the national malaria control programs. So it was, how is this possible that after everything that has happened over this time, this is still acceptable? So we said, no, it's not. So after this tweet storm, we met on Twitter and we said, okay, can we write a letter? And that's how the letter came about.
I want to congratulate Catherine because, and I want to give her as an example that enough is enough, and all the tools can be used. Here it was Twitter, and Twitter make a storm. And this letter they wrote, starting with Twitter, has advanced the agenda of fair partnership. I love that, Catherine.
I have to say it was surprising the kinds of results we've received. When they said, let's put the letter in Nature, I was like, who reads Nature? Then all of a sudden, I'm getting emails from all over the world. That letter. I mean, when the letter was published, the response on Twitter was overwhelming. Everybody said, this needed to be said. And thank you guys for saying it.
Agnes, I know you do not like the use the term decolonization.
People love to call decolonizing. And for me, the colony, we have Lumumba, Nkrumah, so many people who die to decolonize us. And it has a meaning. It's a legal situation of a country without independence. We are independent, but it's something else. And it's the tale of colonization, yes, but it's simply white supremacy. And this is what we see with our colleague, because it all starts centuries ago, because the white supremacy is the pillar of what has brought slavery and colonization. They did so because Europe believed that the white, at that time, they created a theory. They didn't believe that, because if we go in history, at that time, they didn't believe that white was superior. But to justify the colonization, they theorized that we were inferior, our religion were inferior, and that they are there to save us, so that the white people in Europe start to believe it and believe that the colonization was good for us, when the colonization has only one objective: to steal our land and our riches, and to kill all those who oppose to it. That's how we face many genocides that were never reported. So the movement to decolonize global health and to it's okay, but I prefer that it's a movement to fight white supremacy in global health. And that's how I name it. And it's a structural issue, because our partners, the people we are working very well with, really believe that they can help us in malaria program design, where we are the experts. And there are people who have good heart and good meaning and everything, and who really believe they can help us. So they believe also that we are inferior. They don't trust our School of Public Health. They don't trust our knowledge. And they trust that they will manage better for us, when doing so, more than 60% of money will remain there and not serve the purpose for which they received the money. So they are also part of the white supremacy system, because white supremacy is more a philosophy and practice than the color of the skin. Now, but it's based on the same pillar that have allowed slavery and colonialism. And we need to fight that mindset.
Interesting, Agnes. Thank you. Catherine, how do you relate to what Agnes just shared? And in terms of the vision to transform the research ecosystems in this case, in Africa, because both of you are working in Africa.
I have similar sentiments regarding this decolonization debate, but maybe a slightly different perspective as well. And since I'm a researcher, I see the global health system as having different parts. But a big part of that is what I would call the knowledge system. So because the knowledge system, in a way, sort of supports now the practice. And so there are lots of things which are broken, but I think fundamentally, we need to change the knowledge system in global health because a lot of it rides on, the practice rides on the knowledge now. And why? I think one thing that Agnes said, which I found compelling, is that there are different types of global health practitioners. There are those who believe, yes, I want to change the world, but that whole supremacy, the coloniality, the saviorism comes in, and people see themselves as saviors. They see themselves as the people with solutions. So when they come, they never ever think that the people they're trying to help could have their own solutions. And so the knowledge system supports that, because how do you define a problem? You do a literature review. You review literature done by people in the same system. You never ask the people, what is your problem? You do a literature review that is a sort of system there, and then you decide what the problem is. And if something is not supported by the literature, then it's not a problem. If something is not supported by the literature, it's not a solution. But where did the literature come from? You never asked the people. You came up with some system, collected some data, and then you keep on defining the wrong problems, and you keep on defining the wrong solutions because you never listen to the people who will tell you what the problem is. So that's the first thing. Now, there are other people for whom global health practice is a career. So it's a career going somewhere, wherever it is, wherever it takes them, they're okay. So you finish your PhD, you write 200 papers, they get you a professorship, you write more papers, then you get, I don't know what else, you write more papers. And so you throw papers somewhere in the universe. And somehow that is rewarding because the more papers you write, the more promotion, the more grants. So for them, global health is a career. So it doesn't matter what the actual problem is. Their career interest takes precedence. And these are the same people who, after building such a profile, the profile is defined by the knowledge they've thrown out there in the universe. How many papers you've published? What kind of track record do you have? They are the ones who get the influence. They're the ones who get the ear of now the funding agencies. When a funding agency is defining a program, they go back to the knowledge system. What does the literature say? So, as I said, the knowledge system is a big part of that.
If people in Africa dealing with COVID successfully, because in Europe they didn't deal it successfully, write a paper, they will not be published in the system if they don't associate themselves with people who did nothing in the US. So this is a white supremacy system. And I can show you for COVID. It's incredible how people who didn't really succeed have published, and how people who are working on the ground and did things in Africa are not.
The COVID experience has been very eye-opening. Almost a year into the pandemic, I read a story where some public health experts from the US were going to Germany to learn about contact tracing. I was like, what? Contact tracing? Like the art that has been developed by Africans who are trying to fight Ebola. But they are going to learn about contact tracing in Germany, a country that has never done any contact tracing, maybe before COVID. But that's it. And I kept on asking myself, the first few months of the pandemic, there was this whole thing, Africa is not as badly affected as it has been. But almost nothing like, okay, what is Africa doing right?
We have an episode on this, both Catherine and Agnes, on COVID in Africa. And in fact, these are kinds of things we open up there and discuss why Africa has actually seen much better response through continental policies and coordination between countries. So to our listeners, we really looked into that, and it's clear that you have the same sentiment. But Catherine, going back to your letter, you referred to partnerships with northern institutions that are often fully equitable and dignified. They are not. And you wrote that this type of funding has also contributed to a model of implementation that puts the delivery of several health interventions directly in the hands of Western organizations, which further diminishes the capacities and ownership of national programs to deliver to the populations, and ultimately leads to weak health systems and lack of sufficient local capacity. So what does an equitable partnership look like to you, Catherine, and how can we ensure this is realized?
So I think when I think about equitable partnership, we have to look at it in the cross-sectional way, what can be done immediately, but then the fact that the system has undermined capacity within the region, we have to look at the long term. So there are things we can do right now, and those are some of the things we are challenging, that funding agencies, regardless of who they are, should not accept partnerships, quote unquote, should not accept initiatives, quote unquote, that don't have local institutions on them. Mm-hmm. Because as I've said, for some people, $30 million is a career. For me, as an African, doing research in Africa, I don't have anywhere else to go. I have responsibilities, I have a mandate, I have relationships with government, I have relationships with civil society. I'm never going to do a project and after 3 years, I move on and I go somewhere else. I'm there. If I move, my institution is there. So the investing in institutions like ours means that we are able to execute our mandate. We're able to work with these partners, whether they are government or civil society, knowing that we have an aim to solve this problem. We're not going to get a grant because it's something we're going to put on our CV and it's going to look good. And then it will help us get a bigger grant. So that's the cross-sectional thing, that there have to be ways of assessing initiatives that go beyond the quality of the technical work, that look at equitable partnerships, that look at pathways to impact, that look at involvement of voices on the ground, whether they are research institutions like ours or whether they are policymakers or civil society. That is short term. Long term, because I said the way the global health funding model is set up is, as an African institution, it's almost impossible to bid and win a grant from the US government. Because the grants are $30 million, they are $70 million, 150. You can count on your fingers how many African institutions can absorb $150 million. Perhaps there's none. So if you keep that model of saying, you're sort of setting up local institutions for failure, because no one has the infrastructure to bid for $150 million and then deliver it with the kind of burden that is put on institutions for accounting, for reporting, for finance. So the system is set up for African institutions to fail. So our proposal is funding agencies, regardless of where they are, need to invest in African institutions as partners, because the current model may have delivered some results, but it's an expensive model. If you give $30 million and $20 million of it is left in overheads and staffing in northern institutions, and only $10 million comes on the ground, if this was an African institution, maybe $25 million would actually go into programming, and the $5 million would be overheads. So it is a very inefficient model. And if global health partners are interested in impact and in success and efficiency, then the model of giving money to northern institutions to come and work with local partners as sub-grantees is flawed. It's never going to give us the results that we want. So in the long term, we need funding agencies to work with African institutions so that 10 years from now, you have people who can absorb $150 million.
I was in the National Control Commission, permanent secretary, minister. It's a fight to help them to build system. They are ready to teach you how to give a pill, but not to create the system for sustainability. Now, I think there is an opportunity to change, but we need so many changes. We need to eliminate the north-south paradigm in research that essentially benefit the Western world. We need also to treat the researcher the same way. They come from high or low income country, recognize their production and ensure that research questions are proposed by the priorities of the low income countries when it's research to be done in a low-income countries. And co-design, yes, it's not that we are against partnership. We are for equal, respectful partnership where we work together. As Catherine said, we teach, but we teach beyond the management, create system, but also grant writing, article writing, and also how to go for the next research. Create system. You create a research, make sure that this research is embedded in the development of the country. Create a way to collect data, to store data, and to make them to share that other researchers across country and inside the country. So there is a lot of things to do, but change the current paradigm. Give the money, create partnership for sustainability, and no, not for you to exist only. It has to be two ways.
Agnes, you also refer to the education system and as another key area. And I know you also had your own article published in British Medical Journal recently, where you mentioned several challenges to be addressed on reforming education. So this is to both of you. Where can we start doing that? And what are the issues that need to be put on the table in terms of reforming education, preparing the cadre and institutions? Maybe both of you can reflect on that.
It's one of the things I was going to mention about my own perspective about the decolonization debate. And one of those perspectives is the fact that decolonizing is like saying, I colonized, now I am decolonizing. And so we are still the recipients of, goodwill for people who want to dismantle a system that does not benefit us. That's my big problem with this decolonization thing. Right. my sense is in every systems you need to start somewhere. So the system exists as it is, but even though the system exists, we need to think about how do we break the cycle. So we need to start, but very soon after starting, we need to ask ourselves, what is the role of the people who have been colonized? What do we need to do ourselves? Not what needs to be done for us to be decolonized. And so that's where the capacity comes in. That's where the education system comes in. Because I was recently saying that the pipeline is very unhealthy. Our education system is still steeped into colonial practice, our history, our geography, our orientation. Because as Agnes said earlier, our knowledge systems were destroyed. Now we're in this knowledge system that perpetuates coloniality. And therefore, if we are to break this is something that's going to take us a generation. But we need to go very far back. What does our curriculum teach our kids? What are our children being taught about our place as Africans in society and in the world? That is something which is much more long term. But in the interim, for me, in the next few years, I want to be part of an African movement for equity. I don't want to be part of a global movement to be decolonized.
Right.
I'm not colonized, so don't lose your time to try to decolonize me. But also we need to equip the people in our continent to be able to learn and to do research, to have the equipment and the environment to do that. Create system, equip people, teach them in Africa how to do good research for Africa. Don't take them, pretend educating them in Europe, and in fact to have a brain drain canal so that many of the Africans stay there. Bring system here and education in Africa. And we will see what you bring, outcome, be measured. If not, you just continue to develop the Western world.
So another area we have to look at again in this discussion is the role of country and country governments and trying not to be over-relying on external funding and have this continuation of risky situations where that really cuts or changes could affect. So what can be done by national institutions, governments in countries to strengthen funding of research, of capacity, education, institutions? Catherine?
Of course, we live in a part of the world where government investments in research and development are very low. So we can blame our governments for not investing enough in research. But then on the other hand, my perspective is that as a researcher, I have to ask myself, what can I do? Because there are many explanations. We can find long explanations of why governments are not. And my hypothesis is that as African scientists, as African academics, we have not adequately, consistently demonstrated the value that we bring to government in terms of knowledge production and the purpose that knowledge can be used for. Because academics and researchers are part of the global knowledge system. So we do research, we publish papers in the Lancet, and then we call a meeting and we disseminate and we go back home, we get another grant, So the connection between academia and government is very weak in many institutions, in many countries. And so government, when you tell them that perhaps a school of public health needs $100 million every year for research, the Treasury is asking themselves, okay, what are the returns on this investment? Because with $100 million, maybe they can put up 3 different hospitals and then they can win the next election. So that's the connection, our failure as academics and African researchers to demonstrate the value that research brings to the government, I think is where we need to work.
Agnes, what's your view on this? How can we make country investments more tangible and go away from reliance and over-reliance on external funding?
But first, do what Catherine said. Research now are done because we have replicated the Western model that research are for publication first, for improving life after. And we don't do necessary research to improve policies or to help the government to improve policies. In my country, it's a little bit different because I don't say that the investment is what the level I appreciate. But because policies are made evidence-based, the government is interested in research. So I prefer to reform the money as it is now, do research that serve new policies that are more equitable, more inclusive, and more oriented to development. And so with the development, with the growing of our countries, more will be invested in research.
So this is a very complex problem, and we have touched upon some of the key themes, and we've only opened the discussion today. What we are dealing with was created over centuries and decades, and thus there is clearly no quick fix for it. But in our efforts and individual efforts, both of you clearly are working towards this, thinking differently about the issue or taking small steps and vision. You both mentioned to actually see action and see how this can be powerful. In conclusion of our discussion, so our audience can take away some parting thoughts from you on how we can inspire them to start driving change with their research institution in where they are working, with their programs and projects and environments where they are. Maybe Catherine, you can start first.
So I think if I was to give maybe a parting shot, I would say two things. And I'll elaborate on those two things. One is that be the change that you want to see. And then the second is that power is never given. Power is taken. No one who has power, regardless of what form of power, is going to willingly give it to you. So you have to recognize that. And then trying to build your resources, your resilience, your capacity to take. So even that's part of the decolonization debate. The colonizers are not going to cede power. Supremacists are not going to cede power. We have to see in this whole power equation, which power can we take? Because no one is going to hand you power in a platter, whether you're man-woman relationship, rich, poor, political, young, old, power needs to be taken. And once you recognize that, then you realize you have actually more power than you thought you did. It's just that you never realized that you do have that power. Now, linked to that, that's why I said be the change that you want to be. It's not easy, but it's not impossible. So I need to speak out. It's not easy, but unless you do, no one is going to do it for you. And so it's the same, whether you are on your career, you are in an institution. I know that there's always that little voice that always tells you this is not right. It's always there. And so you have to figure out, how do I open my mouth and let that little voice come out? And as I've said, you will be surprised sometimes how easy it is when you open your mouth. Once you've encountered injustice and you think that this is not right, you will be surprised. Even the person you thought would react and be dangerous, they are disarmed by the truth and the courage to speak the truth. So for me, that's what I would say. If we want to be, we have to be the change that we want to be. If we see injustice and we don't like injustice, we need to speak out. But other than speaking out, we need to find what are the things that we can do to dismantle this injustice. And then the next, recognize that no one is ever going to give you power and find ways to take it.
Agnes, your parting thought.
So to add on that, because that's true, we should not sit and wait to the world to be good for us. the world has shown us that during 400 years. I think we need also to educate ourselves, to understand how a power dynamic in systems are created, to understand what equity means really, and to understand that it's our duty to fight for equity and inclusiveness. And this power imbalance between the Western world and Africa, we need to work on that to change it, as much as we need to work in our country for a better life for the vulnerable. And we need to ensure that the research, the education we give work in that sense, and to gather evidence for better advocacy. And as Catherine said, we need to talk, and we need to learn how to do efficient advocacy, educate, advocate, take responsibility, and also show the example of what you do in your own community for equity and inclusiveness.
Thanks so much, Catherine and Agnes. This was really very candid and thought-provoking discussion. You both raised so many valuable points. Thanks for this. So what I took out of this is that first, there is real need to look critically at the knowledge management system, the biases it creates and how it may skew health programming. Second, what I heard is that research systems need to be strengthened in a way that low and middle income countries have the capacity to take the lead on larger projects. Then what I heard that respectful relationships are vital in research partnerships. And of course, lastly, now more than ever, low and middle income country researchers need to be active participants in a movement towards greater equity and inclusiveness. As we come to the end of the first season of the Global Health Matters podcast, we also want to thank you, our audience. I'm so pleased that you've joined us for so many episodes. We had 10 in season 1, and we hope that we gave you an opportunity to look at various topics in global health from a very different angle. We're very grateful to all of our guests who joined us in season 1 and actively participated. Coming up in March, we will be chatting to some of our listeners to hear their feedback on season 1. Please don't miss that episode. We're excited to announce that season 2 will be starting in April this year. We will kick off the new season with discussions on topics such as access to medicines and diagnostics, science diplomacy, migration and health, the role of artificial intelligence in global health, and many others. Until next time, I'm your host, Garry Aslanyan. Join us again. Take care and stay healthy.
Global Health Matters is produced by TDR, the Special Program for Research and Training in Tropical Diseases. Garry Aslanyan, Lindy Van Niekerk, and Maki Kitamura are the content producers, and Obadiah George is the technical producer. This podcast was also made possible with the support of Chris Coase, Elisabetta Desi, and Isa Suder-Dayao. The goal of Global Health Matters is to provide a forum for sharing perspectives on key issues affecting global health research. Send us your comments and suggestions to tdrpod@who.int and be sure to download and subscribe wherever you get your podcasts. Thank you for listening.